satisfaction overall. IMRT, some of the worst urinary and bowel function, moderate sexual function, but they were still pretty pleased. So in summary, again, that's that visual one more time. So this is really showing, for those who haven't been treated, maybe some indication of how they might want to be treated. But for those of you in the audience that have already had your treatment, what can we learn from this data? So I'm going to sound like a broken record, because those that exercise actually reported some of the best outcomes. So those that reported exercising 3 or more days a week had less problems with energy, reported less depression, and even reported better sexual function. Now, I understand that there's probably some kind of a correlation happening here, that those that exercise are probably already healthier overall. There's probably a relationship there, but at the same time, it couldn't hurt. I'm going to keep on pushing the exercise agenda. I'm sure Dr. Wright would be pleased. And also, to eat right. Those that reported at time of diagnosis modifying their diet to take on a healthier diet reported better outcomes and better satisfaction with the outcome of their treatment. So it's something to keep in mind. So in the end, we really need more data. This was, again, a snapshot. This is kind of a concept of where we can go with this registry. We aren't there yet. We obviously need a lot more data so that we can be confident in the kinds of recommendations that we're making. So this is me giving a plug. Please participate. Invite all your friends. It's a lot of fun. I have a bunch of brochures outside, which will have a link to the URL. I do have hard copy versions of the survey that you can either fill out today or you can walk away with and mail back to me. But always contact me for any questions. If there's any way that I can help you fill out this survey, I will do it. So yes, and please remain engaged. This is our URL. Brochures are out front. Thank you so much.
For those of you that haven't seen it, this is what the brochure looks like, and the website's in the brochure. And what we hope to do is have this be longitudinal, so we can see how symptoms evolve over time, get better, get worse, be able to collect that information. And also there's a consent to contact. If in the future there's a particular research study that we think may benefit you, the idea is we could contact you and just tell you about it. You're obviously feel free to decline if you don't want to participate. And we're sending these brochures around to all the urologists around the state and also the medical oncologists, but and the support groups, yes, as well. So we'll have a little QA here. Bruce and Paul, can you guys come up to the front? We've had a couple questions already, and please write others down. The first question was, are copies of the slides available? So these will all be on YouTube, and we'll have a link to those on the website where you registered. And so just probably in a week or two, they should be up, I would guess. We have to curate them a bit. Okay, Dr. Lang, are there any studies on men with metastatic prostate cancer opting to keep their prostates based on quality of life?
Yeah, I think so, because if you're going to do, first of all these patients are put on hormones. So potency is not really an issue in that case, with or without. But there still is urinary incontinence and this sort of thing. If you're not incontinent before, you might be afterwards. But let me just say one thing. I want to bring something up because it's a little bit, but let me preface it with a little story. Dr. Jewett was a famous prostate cancer surgeon at Hopkins. He was a rather cocky guy. He would go around the country saying, you know, I've only had 2 patients who were incontinent from my surgery and the thousands of patients I did. And a doctor from Maryland got up and said, Dr. Jewett says, that's amazing because both of your patients are my patients. You know, as my wife said, and when I had my surgery, unfortunately it change me, but the problem with, and I'm all for these surveys, we need to know what it is outside, but the difference between a person who does a few of these cases and a person who does a lot of them, and the difference between a patient who's a talented surgeon and a patient who's not, are significant. Whereas in radiation therapy, while there is certainly a difference, Dr. Russell is one of the best I've ever seen, in general, there isn't this wide difference in skill and in results when it comes to the radiation. And so that gets to be a problem when we take these very large surveys and try to decide, you know, what's best for you depending upon who's taking care of you. By the same token, if you look at the major centers where they claim, we're one of them, that we do pretty good surgery stuff, there still is significant incidence in incontinence. And I think in general it's slightly worse in terms of potency than radiation, at least initially, although later on it comes down. So I just want to, in these general surgeries, this is very important, and I hope we are more successful in getting more people in the state to participate. But you have to realize that there is a little bit of a caveat when it comes to these two things.
All right. The question is, can someone still join the Stand Up to Cancer study? And if this is for Dr. Montgomery, if a biopsy shows a DNA repair deficiency, why wouldn't you treat a patient with a PD-1 inhibitor, pembrolizumab, versus starting them on testosterone suppression up front and then going to the usual progression of Xtandi and enzalutamide, et cetera?
Sure, that's a great question. So, yes, in fact, right now the Stand Up to Cancer effort is still open at our institution. So folks who are not responding to standard hormonal therapy can participate in having a biopsy done. So that is something that's ongoing, and we would strongly suggest that anybody who's interested in finding out this sort of information come to talk to us about that. So that's first. Secondly, the issue is if we did find a DNA repair deficiency. So again, just to reemphasize, there are two different types. There's the type that is the BRCA type, and then there's the mismatch repair type, which is the one that may predict for a response to a PD-1 inhibitor. So the issue of deciding, should we go with something that's very, very experimental, and for which right now the amount of data is, I would say, anecdotal, versus doing something that has been shown to improve outcomes for people, like hormonal therapy. I mean, I think that the issue is there a reason to not do both, really? I think that would be my argument, that is, why not double down? One of them definitely helps. The second one, meaning the PD-1 inhibitor, might help, and certainly we should be talking about whether participating in a study that would answer that question and potentially benefit somebody should be done. And I think that would be my general approach to that, although, again, I'd be interested in whether Dr. Nelson shares that thought.
I do. How long does it take to get the results from sequencing?
Yeah, so we've been getting better. When we started the project, it sometimes took somewhere in the range of close to 4 or 5 months. We have been getting results back within somewhere in the range of 2 to 3 months, so it's still not as fast as anybody wants it to be, but we are getting better at getting those results back.
And what's the cost of doing it if you do or don't have insurance coverage?
Sure. So in participation in the Stand Up to Cancer effort, there's no cost. It's free. If somebody is not participating, so we do actually have biopsies that can be done as part of multiple other research studies that we do. A lot of our approach to all this, and this is largely a reflection of our idea from the very beginning, that you can't figure out what cancer is doing unless you have the cancer in hand to interrogate. We've been doing studies looking at prostatectomy specimens that are 10 to 12 years old, trying to figure out what's going on with somebody who's dealing with a real problem, so much later and saying this has some relevance to what's going on in that patient. And for most of the biology of what's happening in a man dealing with resistant disease, what's in the prostatectomy is irrelevant. There are some things we can get out of a prostatectomy that are relevant, but not very many. So I think, so you can participate in a other study that involves getting a biopsy, and we will do sequencing for free. If you did it outside of any research study, the cost of a biopsy for clinical indication, we can actually do a biopsy if there's just a bone biopsy, posterior iliac bone biopsy in the clinic at the UW for essentially nothing. The sequencing, if it's covered by insurance, is obviously free. That doesn't happen very often, and out of pocket, it's $5,000 just for the sequencing. The actual biopsy is, again, if not covered by insurance, is probably close to the same cost. So these are things that Joe Biden is working on changing, and all of us are trying to change because, frankly, with the information that we know, and some of which I talked about today, we should be able to do that for every man in the room who's dealing with advanced prostate cancer. But, that's something we need to work on in the years to come, everybody in this room and us, to press your senators and everybody else you can to make this what we can do every day for clinical utility.
So there's kind of two answers to that, and then Dr. Montgomery answered the idea of the tumor. The patient vignette that we showed on the video surprisingly was found to have an inherited mutation in the BRCA gene, which he didn't have a very strong family history that would have made you suspicious, and that's what was surprising. And then his daughter was tested and also positive, which completely surprising, but now she's under intense surveillance. So there is a very low-cost approach to having the germline, that is what you're born with, sequenced. There's a company right now, and there's others around that'll be doing this, called Color Genomics down in San Francisco. And Dr. Montgomery has already been working with some patients to approach it this way. But basically, we think, our opinion is that every man with metastatic prostate cancer, the aggressive variant, should have their germline tested. Insurance won't pay for that generally right now. So this company, what this company does, Color Genomics, is if it's ordered, we fax them an order, they receive that order, they send you at home a little kit that you just swish in your mouth and spit into a tube, and there's enough cells sloughed off just from your oral cavity. You can FedEx it back to the company, and they sequence these key genes, both the genes that are involved in hereditary hypermutation as well as these other genes involved in the breast cancer and ovarian cancer. That costs $250. So pretty reasonable considering the information you get back. And so Color, C-O-L-O-R, like just, red, blue, green. Genomics. But you still need to have a physician order it, but it's not an insurance paid for test. They'll send you a bill for $250, and I don't know what the turnaround is. You've had experience.
It's 4 to 6 weeks, roughly. I think they quote a little bit shorter on the website, but that's what it's been most recently.
So our results suggest 1 in 10. So, hopefully you're not going to have inherited that, but it has important implications for your specific treatment as well as family members in thinking about screening. So that information is going to be out there soon, hopefully in the next several months, much more publicly. Right now, prostate cancer isn't really thought about in these familial sort of syndromes, right?
I just want to add one thing about that. 3 years ago, I looked into this. It was $4,000. There was one lab in Salt Lake City that did it. It came down to $250. I was immediately suspect if it looks too good to be true. It is, but I did vetted it in some ways that I could. It's the same exact test. And also telling you about the power of, when you said it takes 4 or 5 months to sequence the genome, how that shrunk. 3 weeks and $250, and you got what you need.
Yeah, it does a selected, this key group of hereditary genes, so this isn't sequencing the tumor. Again, there's 2 different parts to this. Dr. Lang, for patients with low metastatic load, what we would call oligometastases, probably a few sites, It sounds like treating the primary tumor in the prostate with brachytherapy might be helpful. Is that right?
Right. I think all of the treatments are focused on destroying the cancer in the prostate, whether taking it out or radiating it. Most of the trials that I showed you were external beam, but in at least one of the trials, you could get either, any kind of radiation, whatever is the therapy recommended, either radiation or surgery.
Great. So a quick answer, is there a test to determine if you have an ATM? That was one of the mutations Dr. Montgomery talked about, mutation. And yes, these tests of biopsying the tumor, all of them, our Oncoplex test, the Foundation Medicine test, the Stand Up to Cancer test will all tell you if there is or isn't. Is there an understanding why some prostate cancer cells require testosterone to survive and others don't? And if so, is it possible through a blood analysis or otherwise to estimate for a particular patient the time until androgen deprivation, testosterone suppression will no longer be effective?
So there are a couple of different aspects to that. So there are cancers that right out of the box don't require or use testosterone to survive. So prostate cancer can be derived from multiple different cells. The prostate is not made up of one cell. There are actually multiple different cell types in the prostate. So there can be a very rare type of cancer that develops de novo, like right out of the box, called small cell carcinoma. That cancer does not use testosterone at all because it does not express what's called the androgen receptor or the testosterone receptor. So that is a cancer that is completely hormone independent, truly hormone independent. There is this growing recognition that actually because we are doing a much better job of pressing on the testosterone signaling axis in advanced disease, that there may be a propensity for those cancers to develop over time more commonly than we recognized before. That's still a little bit controversial, but there are some really, I think, elegant studies that would show that that probably is real. The idea that there are different levels of androgen dependence is really all about how differentiated the cancer is. And a small cell cancer is completely undifferentiated. Gleason score is one measure of that differentiation. So a very high Gleason score tumor is sometimes less differentiated and less like the tumor, the tissue that it developed out of. So it's less dependent on the things that the normal prostate is, and normal prostate is in large part very hormone dependent. So I think the idea that there is a gradation for androgen dependence is partly, it is to some degree determined about the cancer that develops from the very beginning, but also we're finding that our therapy can also to some degree influence that. And again, Dr. Nelson has done some really important work in this area, and he can, I think, actually be the one to comment about the blood tests for this, because he's leading our effort on what's called circulating tumor DNA that can give you a sort of a shot at what's going on in the cancer itself. Do you want to talk about that?
Sure. So we would all, and I know you would all, like to avoid a biopsy. It turns out that as tumor cells grow, many of them die. And as they die, they release their DNA into your blood all the time. It's not dangerous. It doesn't go off and infect other cells. Your body just clears it out. But there's a period of time when it is accessible then by a standard blood draw. And it turns out that there's some early evidence that if you can acquire, pull out, isolate, purify that DNA, you can actually sequence it in the same way that Dr. Montgomery was describing sequencing the tumor. So I think over the next couple years, this field is advancing so quickly that we will be able to ascertain in many men, perhaps not all, the composition of the metastatic tumor by a blood sample. What that allows you to do is also sample it repeatedly over time as it may respond to a therapy and then resist. So one of the mechanisms that we understand that can cause a tumor cell to resist low testosterone therapy, or even the drugs like enzalutamide designed to block the receptor, is that there's a variant of the androgen receptor, which I like to describe as the molecular engine of that tumor cell. And this variant is called a splice variant that doesn't need testosterone at all, but it still turns on the tumor cell the exact same way. And this variant predicts resistance then to the Zytiga, abiraterone, and enzalutamide. It's not a commercial test yet, but it will shortly follow. And it may point someone into choosing a different therapy, including there are some new drugs coming along that block a different part of the androgen receptor. And Dr. Montgomery has a phase 1 study of one of these drugs that's just getting ready to open. And so that maybe is a long answer to the question about we don't have accurate ways to predict how long someone might respond, but we do have methods to start telling at a point in time how that tumor started to resist the therapy and hopefully point you in the direction of a therapy that should have efficacy. We're going to stop with the QA. I want to be respectful of everyone's time, so we'll excuse all of you from the front, and I'll just have 1 or 2 closing slides, and then we'll wrap it up. I really don't want to go overly long here. So, Nola, I don't know if you have the last slides up here. Didn't see them on here.
Here we can just go all the way down to the bottom. Oh.
Right there.
Huh.
They weren't on the deck.
Mm-mm.
That's okay.
Okay,
I'll just
sorry.
say- So those slides are missing, so we'll just wing it here. So I'm very grateful for all of you for attending this today. And as I started off the entire introduction to the symposium, we view this as a partnership. We will never make advances attempting to cure this cancer and prevent this cancer without altruism, without participation in clinical studies, without feedback to us, whether it's through the MPower study or in the clinic every day, or telling your senators and other government officials to support the cancer research. There are 2 development folks, I think. I'm not sure Mike Rubin is here. You can contact NOLA if you have questions and want further feedback or opportunities to come in and visit the center. I encourage you to visit the websites. And thanks again for attending, and I want to thank our speakers for giving you the information. Safe travels. Bye-bye.